Hello, good morning.
Good morning.
Okay. So what is the most useful next investigation for this patient? Okay. 43-year-old woman present with the neurology clinic complaining of polyuria, polydipsia. She has been feeling constantly thirsty and she has been taking lithium carbonate. So BP pulse 88, she has postural drop 10 millimeter on standing. So, okay, what is the next investigation for this patient? MRI brain, sodium, potassium, ultrasound, ADS measurement, water deprivation test.
Water.
Water deprivation test. Okay. Yeah, this one. 24 dermatology clinic, blistering lesion on his lower limb. Achha, he has just returned from a trip to Cameroon. Identified and removable as shows below. What is the most likely diagnosis?
Cameroon.
কি হবে এটা? Anisakiasis, filariasis, cutaneous leishmaniasis, diarrhea-filariasis, trachocularis. I have no idea.
No idea.
Dracoculasis. Dracoculasis is known as the chikungunya worm infection caused by the Dracoculius medinaceus. Infection is transmitted by the consumption of the unfiltered water containing small crustaceans infected with larvae. An extensive World Health Organization program has eradicated the disease in several countries. Although causes are still seen in many West African countries. The worm lies under the superficial blister-like lesions and track from by the worm and can be identified under the skin. The incision is usually made. The worm is wound slowly around the stick to remove it from the subcutaneous space. Dracoculiasis. এটা কি worm?
না না ওটা বেঁধে রাখছে
সেটাই তো Dracoculiasis. What is the most appropriate next investigation? Most appropriate next investigation. Okay. So 29 old admitted ED, abdominal pain, distension. She has hardly eaten for the past 48 hours due to nausea and opened his bowel between 6 to 8 times per day for the past few days. He has experienced bloody diarrhea and mucus. His symptoms are usually controlled with mesalazine. Although he began a course of prednisolone 4 days ago, temperature 37.9, 170, 98 regular. His abdomen generally tender and moderate distended with acute active bowel sound. Hemoglobin low, WBC raised, platelet sodium, potassium, okay. Creatinine 139, CRP 219. What is the most appropriate next investigation? Ultra, X-ray, colonoscopy, flexible sigmoidoscopy, stool culture. X-ray.
X-ray, megacolon.
So X-ray investigation choice to rule out the presence of toxic megacolon in severe exacerbation of ulcerative colitis. Evidenced by the presence of 6 or more loose stool a day with the blood and systemic upset. The diagnosis of the ulcerative colitis is clear here. Blood in the stool and use the mesalazine pointing away from Crohn's disease. So toxic myoclone at the transverse or right colon is usually most dilated. It is frequently more than 6 centimeter, occasionally up to 15 centimeter on supine flame. The supine 15. Descending colon is less frequently dilated, and sigmoid colon or rectum are rarely distended. Persistent dilatation or symptoms not improving despite medical intravenous intervention and indication for surgery. Irregular, বার prick এরকম মতো লাগতেছে অনেকটা. What is the most likely cause of the barium swallow appearance? 72 years old man present with the gastroenterology clinic to discuss his barium swallow result. He has suffered from the progressive dysphagia, initially to solid and now to liquid. Blood tests have revealed the iron deficiency anemia and elevated transaminase. What is the what result of his barium swallow show below?
Achalasia, maybe. Or esophageal. Long.
Transaminase বাড়ছে,
Cancer.
হ্যাঁ সেটাই তো আমার কাছে লাগতেছে, ডিসপেজিয়া আবার ট্রান্সঅ্যামাইনেজ বেশি, অ্যানিমিয়া আছে, আয়রন ডেফিসিয়েন্সি। ইউজুয়ালি তো একালাসিয়াতে তো অ্যানিমিয়াটা হয় না, তো কাছে ক্যান্সারটাই লাগে। Progressive dysphagia with iron deficiency anemia coupled with the tapering on the barium swallow raises the possibility of the esophageal cancer. The irregular appearance of the esophagus below the taper fits with the diagnosis. An endoscopy to biopsy the lesions and assess the suitability for stenting in the logical next step. Given the extent of lesion, it is already likely to have metastasized. Liver চলে গেছে, metastasis হয়ে গেছে। What is the most likely diagnosis? ESF raised to CK48, calcium 2.9. Okay. A 74-old woman presents to the musculoskeletal clinic complaining of severe stiffness and pain, which affects her shoulder and hips for the first few hours and every morning. It often takes her 2 or 3 hours to get the downstairs for breakfast. The pain persists despite the maximal dose of ibuprofen and paracetamol. BP raised 165/95 to 73 regular. PMI 23, power 4 out of 5 to working, weakness affecting the shoulder and hip muscle. Hemoglobin okay, WBC, platelets, sodium, potassium. Yes, sir, it's raised. What is the most likely diagnosis? Cushing, hypo, PMR, polymyositis, rheumatoid arthritis. PMR?
PMR.
This patient has the normal weight, calcium, CK, and is marked elevated ESR, considering the proximal myopathy and morning stiffness. PMR is the most likely diagnosis. Oral prednisolone intervention of choice, and 12.5 milligram per day is usual starting dose. In patient whose symptoms do not respond completely, this can be increased to 25 milligram. Typically, an improvement in pain is seen within 40 to 72 hours after starting the steroid therapy. 12.5 the শুরু করব, then বাড়াবো 25.
How to differentiate from chronic fatigue syndrome?
Patient complaints fatigue.
Chronic fatigue syndrome. Chronic
Yeah.
fatigue syndrome, they'll have similar complaints. How to differentiate?
Patient complaints fatigue more.
ESR and CRP.
Yes, ESR and CRP will be normal in case of chronic fatigue syndrome. Similar complaints, elderly, so but those things will be normal. Whereas one more thing is Fibromyalgia, how to differentiate from fibromyalgia?
Fibromyalgia, uh, patient has regional pain like
That
Multiple
11
tender
point,
points will be.
11 point tender, 11 tender
Yeah,
point.
pain out of proportion.
Yes.
Hmm. Okay. So this is the lesson. What is the most likely diagnosis? L-port, bilateral, kidney stones. Okay. First to read the question. A 68-year-old man referred the nephrology clinic GP. Investigations see the chronic renal impairment. Creatinine has progressively increased from 130 to 205. Latest measurement. Her GP has also noticed hematuria and 2 occasional over the last 3 months. So blood pressure 149/85, 80, and her abdomen is soft, non-tender, suprapubic origin, palpable bladder. So hemoglobin low 91 and WC 10.2, platelets, sodium potassium raised 5.4, creatine 205. So CT scan, her abdomen is contrast below C. This is something wrong, eh? And also here,
Is
Bilateral
hydronephrosis.
hydrator nephrosis.
yeah, bilateral hydronephrosis. So now diagnosis is bilateral
PCC.
transitional cell carcinoma of the bladder. But that didn't give any hematuria or anything.
They've given hematuria.
Huh.
Elderly gentleman with hematuria.
Oh. The CT scan here shows the bilateral hydronephrosis with the dilated ureter seen on the CT slice, coupled with the hematuria and progressive increase in the serum creatinine. This is consistent with the diagnosis of TCC of the bladder. It is likely that underlying cancer can be visualized on more distal CT scan slice. Bilateral nephrostomies to relieve the obstruction are likely to be required. What is the most important component of therapeutic drugs monitoring in this patient? 72 years old man with review in the movement disorder clinic as he has begun experiencing psychotic episodes. He believes that there are people in this house who are threatening him. He has been violent towards his wife during those episodes. He has end-stage Parkinson disease and has been commenced on clozapine. So clozapine, that means we check regular WBC, CBC, that means WBC including neutrophil differential agranulocytosis. Neutropenia is the key adverse effect of the clozapine therapy and subject of the black box of the medical. Oh, no, everyone. What is the most likely cause of the episodes of BT seen in this patient? A 71-year-old woman admitted to the emergency department following the collapse. Upon arrival, she underwent an episode of ventricular tachycardia, for which she received a 150 joule shock, and she had an aortic valve replacement 12 years ago, and pacemaker was fitted afterwards for impairment of the AV nodal conduction. On arrival in the unit, she has a short chest, but she is conscious and oriented. So BP 140/82, 65, chest clear. Her blood are unremarkable. What is the most likely cause of these episodes of BT seen in this patient? So QT, long QT, brugada, myocardial ischemia, pacemaker lead displacement, under sensing of atrial and ventricular signal. Is it displacement?
Undersense or lead detector.
Most likely under sensing only.
Undersense, definitely.
But why we say this is under sense?
It's RNT phenomena. Basically, it's not sensing, and the pacemaker is delivering when the patient is having his own heartbeats.
Okay. The BT can be driven in patient with the pacemaker. In the presence of ectopic ventricular complex, undersensing of the ventricular beat drives the delivery of a ventricular pacing stimulus. When this occurs at the wrong time, it can deliver a stimulus that participates BT. Pacemaker-induced BT can be avoided by the inducing pacemaker, which include the atrial demand and pacing mode. I don't understand this point. Can you explain again?
Even I didn't get last sentence.
39. Okay. Something. What is the most likely diagnosis? Huh? Okay, read the question first. 73-year-old man referred hepatology clinic GP after presenting with the tiredness, lethargy several months ago, coupled with the abnormal liver function test. He admits that he goes to a pub for lunch every day and drinks whiskey every evening. He has done so since the death of his wife from the cancer 5 years ago. He smokes 10 cigarettes per day. Examination abuse soft, although there is the mild tenderness in the right upper quadrant. You note the multiple spider nevi of his upper lobes and body mass index 22. Hemoglobin low 109, WBC platelet low, sodium, potassium, creatine, ALT raised, AST raised, AST raised, and ALP okay. Bilirubin 15 and anti-smooth muscle antibody negative. Ultrasound scan given here.
Double in here AST, right? From ALT.
No,
No,
double.
not double.
Not double.
Not double. Okay.
But ultrasound reveals that this is not homogeneous, like I think so. This is hepatomegaly like picture. Irregular shape.
How we say it's irregular shape?
This,
Okay.
this is the liver.
এখানে কি in here the gallbladder is
This one.
Okay.
What is the most likely diagnosis? Alcoholic cirrhosis, autoimmune hepatitis, hepatocellular cancer. It is most probably hereditary disease. Hepatocellular cancer.
Is there any weight loss or something they given?
Any patient is anemia.
No,
Anemic, but patient. Okay. But patient have lots of alcohol abuse thing, and patient has noted spider nevi upper.
So
Cirrhosis, I think.
So alcoholic cirrhosis.
It's not autoimmune because the antibody is not present.
Yeah, not present, but is it alcoholic cirrhosis or hepatocellular cancer? Patient hemoglobin is low.
It's cirrhosis actually. You can look at the liver texture actually. Echo texture is quite thick. Yeah. Generally, it will not be this much thick. It will be kind of black things will be there. It is more white. So it will be cirrhosis.
Okay, let's see. The patient has blood picture suggestive of the alcohol-related liver disease with elevated transaminase and ALP. Anemia with a low platelet, abdominal liver ultrasound scan. US scan here shows the hypertrophy of the caudate and loop and coarse liver texture. Consistent with the cirrhosis. The alcohol history are relatively low BMI and pointers towards the alcoholic liver disease rather than NASH. Prothrombin time should be measured and patient should undergo the liver biopsy to assess the degree of cirrhosis. In addition, should be encouraged to reduce the alcohol consumption. What is the most appropriate treatment option for this patient? Okay, a 29-year-old woman present to the urgent gynecology clinic complaining of pain during sexual intercourse on deep penetration. She also experienced intermittent bilateral lower abdominal pain and bleeding on some occasion following the sexual intercourse. So temperature 37.8 and bimanual vaginal examination reveal adrenal tenderness, while the speculum examination revealed the mucopurulent cervical discharge. And nucleic acid test for chlamydia is positive. What is the most appropriate treatment option for this patient? IM ceftriaxone 500 single dose, ceftriaxone single dose oral azithromycin, IM ceftriaxone, doxycycline, metronidazole, doxy twice daily, moxifloxacin twice daily, Septra, doxy, metro, PID. No?
PID.
Mm. So this is the preferred combination treatment of PID. The likely diagnosis here. This is evidenced by the adrenal pain, chronic cervicitis, bleeding after the intercourse. The positive nets chlamydia adds further weight to the diagnosis. According to the British Sexual Health Guide, triple antibiotic therapy should be used. This should comprise the single dose of ceftriaxone followed by a course of doxycycline and metronidazole. Alternative regime can include the quinolones, although these are no longer considered preferred option in the UK because the neurological and musculoskeletal effect associated with their use. Morning cortisol, overnight dexamethasone suppression test হচ্ছে 32. That means decrease less than 50. So what is the most likely diagnosis? Acromegaly, Cushing disease, Cushing syndrome, impaired fasting glucose, type 2 diabetes. Okay, we read the question first. 45-year-old man presents ED in discussion with the result of recent dexamethasone suppression test. She has gained 15 kilo in weight over the last years. He admits that drinking 4 pints of beers per day and examination BP okay 32 BMI. So hemoglobin higher, okay, potassium 3.9, sodium okay. Cortisol level 450, glucose fasting.
But it is a 16-hour. The cortisol level is not the morning cortisol, it is the evening cortisol thing. Is it do you do at 16-hour cortisol level, or we do the 9 hours and
We do the 9 hours usually.
right? 9 hours and midnight, right?
Yes, midnight and 9 hours. Here fasting sugar 8.4 and overnight dexamethasone, that means 9 hours fasting sugar is 32.
That means depressed, right? This one or what? I am so confused with this level.
Suppressed.
Suppressed. That means
So it is not Cushing syndrome.
Syndrome or not disease.
This is, I think, type 2 diabetes.
Might be.
Type 2
Because
diabetes.
patient fasting sugar is raised 8.4.
And so we didn't count this thing, right? The cortisol level 450.
Normal.
Yes, normal. Adrenal gland is functioning. This patient has poor lifestyle and is overnight with excess calories and alcohol consumption. This lifestyle has led to weight gain over the past years, and new diagnosis of diabetes mellitus can be made. Evidenced by the elevated fasting sugar, glucose, although this 16 hours cortisol is elevated, this is not diagnostic Cushing disease. Low dose dexamethasone suppression test is needed to confirm the diagnosis. 58-year-old man present to the neurology clinic. He has been experiencing right-sided hearing loss, vertigo, tinnitus, which have worsened over the past years. He has been loss of sensation over the right-hand side of his face. So MRI of the brain given below.
Acoustic neuroma, CP angle.
CP angle tumor, right? This one.
Yes, yeah. So what is the most likely diagnosis? CNS lymphoma, glioblastoma, hemangioblastoma, meningioma, vestibular schwannoma. But usually vestibular schwannoma happened bilaterally. This is unilateral. Progressive hearing loss, vestibular dysfunction, and tinnitus are slowly growing, and patient may experience symptoms of several.
Vestibular schwannoma in case of bilateral, if it is neurofibromatosis type 2, on that case it will be bilateral, right? Otherwise, it can be unilateral.
Yes. Patient experience symptoms for several years before the presenting clinicians, although vestibular schwannomas may impinge on the both trigeminal nerve and the facial nerve. Loss of sensation is more likely than the weakness. They are well circumscription which develops at the cerebellopontine angle and can be enhanced on the MRI scan using the gadolinium. Heart exudate. What is the most appropriate intervention for this patient? Okay. A 54-year-old man is referred to the ophthalmology clinic as he has been experiencing worsening blurred vision affecting his left eye over the last 3 days. Type 2 diabetes and glucose control has been poor over the last 3 years. He has transitioned to the long-acting insulin in addition to the metformin liraglutide over the last 4 months. His most recent glycosylate hemoglobin 54 and retinal thickness measured by the optical coherence tomography is 550. Photographs even below left-sided. It's a hard exudate. Eh?
Other things, these are the bleeding thing, hemorrhage. The also the new vascularization. I just know this is the heart exudate, but but the other part, the down part of this retina, is this are the bleeding?
Yes, this is the bleeding. I think so.
Bleeding is there, neovascularization, then hard exudate involving macula.
So it is a maculopathy.
No, it is a proliferative diabetic retinopathy with maculopathy. PDR, basically.
So,
proliferative diabetic retinopathy.
Proliferative.
If a macula is affected, then we can say it's a maculopathy. It doesn't.
There is neovascularization.
Yeah, that's the thing I want to see.
There is a macular involvement. We have to give the macular.
This bleeding and all generally indicates that proliferative is there. The small things in the center, you can see small things, aneurysms.
You can draw here.
Neovascularization is tricky for me.
Yeah.
Go.
This is intraretinal anemia. That is maculopathy is there.
Yeah.
No, it's acute. No, acute. It will be generally PRP is intervention of choice, no? Right?
PRP, the pen.
How can we say it is acute?
No, first. Oh.
But
I know that
macula is
ranibizumab.
But I solved few more question where only macular edema is there, where focal therapy is the treatment of choice in past test.
This past test is so much a contradicted thing. They make us so much confusion.
Ranibizumab is the antivascular growth factor, but here why didn't give photocoagulation, pan-retinal photocoagulation.
Dr. Rajavardhan, that one is the laser phototherapy, not the pan-retinal photocoagulation.
In case of proliferative class polyperative, we can give pan-retinal photocoagulation or the laser one.
No, even in the maculopathy, you can go for that laser phototherapy, not that pan-retinal. Read now, pan-retinal, you get it.
Okay.
But in past test, they give one question like this. They give this.
Yeah.
In past test, if there is no PRP option is there, then only we'll go for ranibizumab.
Yeah.
That's what I understood after solving past test.
No. There is a laser, not the PRP one. Read this one. You get it.
Okay, anti-BEGF agents and the intervention of choice for diabetic macular edema. The diagnosis confirmed by the retinal photograph, which shows the multiple small hemorrhages and sarcinate heart exudate. The nice guidance on the diabetic macular edema enrolls the ranibizumab when the retinal thickness is more than 400. Patient retinal thickness was 550. Aflibercept and bevacizumab potential alternatives, and when the anti-BEGF agents not suitable. Contraindication or only potentially effective, then the focal laser photocoagulation is the alternative.
They go for this laser.
Focal photocoagulation, not
Yeah,
quite-
look, they are saying that if it is the drug is not
Working.
sufficient, yeah, then you can go for that focal laser therapy.
But first step, we have to go for the drug, then go for this.
Yeah.
scan.
Whenever you see the maculopathy, like even the wet macular degeneration, we give that VEGF.
Mhm.
Okay.
So now we focal is there. First we'll choose focal, then VEGF, then PRP.
No. First VEGF. If it is not
No,
working,
focal
then
is there. If focal photocoagulation is there, it is panretinal.
yeah, not pan-retinal.
Okay.
What is the most likely diagnosis? Urinalysis protein negative blood plus ESR 87. 72 years old woman, the presence to the acute medical ward, deteriorating health, which has worsened over the last few months. He complains of weight loss, night sweats, and she has also been experiencing joint pain, stiffness, particularly affecting her shoulder and hips, which is worse in the morning. And GP prescribed 24 milligram prednisolone per day, but this has not impacted her symptom. 155 by 85 and pulse 69 regular. Abdomen is soft and non-tender, no mass or undetected. So hemoglobin low and creatine okay, 87 ESR 3 plus blood. So what is the most likely diagnosis? CGA, GPA, PMR, renal adenocarcinoma, TCC of the bladder.
Polymyalgic rheumatica.
But why bleeding present? Hematuria 3 plus.
Oh, no, 1 minute. Patient steroid is not response. Can you go up?
This one is adenocarcinoma, that paraneoplastic feature of PMR.
Oh,
Adenocarcinoma.
Yes.
Yeah. This is a.
Steroid is not, it is not
Yes, it is not PMR. It is renal
Renal adenocarcinoma.
adenocarcinoma. Sometimes they have a PMR like feature.
Antibodies.
Patient hemoglobin low, 3 plus blood on the urine. So
Yeah, it's a renal adenocarcinoma.
weight loss. That's
Night sweat.
the patient demonstrated the marked hematuria symptoms of underlying neoplasm suggested by the night sweat and weight loss. She may have the renal tract carcinoma, either an adenocarcinoma of the kidney or TCC of the bladder. Symptoms of polymyalgia-like syndrome are described in association with the adenocarcinoma of the kidney, are said to resolve following the nephrectomy. They normally respond poorly to intervention of choice with the corticosteroid. Other paraneoplastic symptoms associated with the renal carcinoma, including polycythemia, hypercalcemia, which are result of increased the erythropoietin and parathyroid hormone-related peptide production. 65-year-old man presents to the ED following a third episode of angioedema in the past 9 months. She takes a number of medication, including ramipril, bisoprolol, amlodipine, atorva, indepa. What is the most likely cause of this patient's symptoms? Increase angiotensin 1, angiotensin 2, bradykinin, and decrease 6-keto prostaglandin F1 and decrease
Bradykinin.
lysine.
Bradykinin, because the angioedema, AC inhibitor.
Is the pathophysiology of angioedema.
Also seen in that C1 inhibitor, C1
Yeah.
inhibitor deficiency.
Hereditary.
Yeah, hereditary.
What is the most appropriate way to does this patient's hydrocortisone? Patient may be intercurrent illness. So,
Pregnant, a 38-week pregnant, the term patient. She has adrenal insufficiency. She is currently taking 15 milligram hydrocortisone.
Basically, Addison disease patient taking steroid and is 38-week pregnant. How we will manage the steroid dose?
This one is the
We have to increase
100
Increase the dose. What are the
maximum.
options?
Yeah, 6 times.
6
The
times.
answer will be the A.
All have done
100.
multiple
Yeah.
times.
Repeat every
Yes.
Yeah, until
Our
the
answer.
delivery, yes.
No, because we are discussing lot of time behind that topic. That's why we
Yeah.
remember.
The discussion master.
how much we raised?
I
Like
think
100
next 2
milligram.
years you will be heading RCP examination. Okay.
Please give us such blessing.
Yeah. Bolus. In case of labor, the significant physiological stress in this patient, the adrenal insufficiency, and in case of a corticosteroid replacement is recommended until the birth. Liver can affect the absorption of this drug from this GI tract. So IV steroid replacement is the preferred action. According to the Addison's Disease Society guideline, the dose of 100 milligram every 6 hours is recommended. When we read this question the first time, we are saying, okay, just double the dose. But seeing the answer, everyone, yeah.
They have tricked in many questions. I have, if I can recall, there are 5-6 questions regarding the dose and the clinical situation
In the past
regarding
case,
Addison.
they have this type of question, like for
Yes.
runner, for strenuous activity, what we can do, like this. Lots of questions were at past medicine. They have this dose related.
Okay, anyone can go for that hereditary angioedema management part. Any once just. What is the prophylaxis? Prophylaxis, there is a 2 1.
Prophylaxis is I forgot the name of, but that is a C1 inhibitor drug.
The 2 things, I think tranexamic acid, danazol, and PCC. Sorry, not PCC.
In case of
C1
acute
esterase
condition,
inhibitor.
in case of acute condition, we have to give 2 type of prophylaxis. One is danazol, one is tranexamic acid. Tranexamic acid for the
Danazol is for prophylaxis, TXA is for acute intervention, and PCC is in case if the patient has some acute presentation in ER or some stridor or something. Yes.
Look, all people, look here. I think for the prophylaxis, short acting is tranexamic, and for the long acting is the danazol.
Yeah.
Danazol, yes.
For the management purpose, we have to give C1 inhibitor, esterase inhibitor. If it is not available, go for FFP.
Yeah.
And if it is there is a icatibant like drug, then we can go for the romlipostine and icatibant something.
Romlipostine or the
icatibant.
The drug name is with C.
No. Icatibant. No. Yeah, icatibant one I forgot. Not the romlipostine. Sorry. Okay, go ahead.
Rojapu, to continue করেন না?
Wait. I can read.
Okay.
What is the most appropriate next intervention? So, 62-year-old woman present to the respiratory clinic for review. She complains of worsening shortness of breath, which has developed over the last 3 months. She was diagnosed with the COPD 2 years ago, for which she was prescribed a salbutamol inhaler. Her post FEV1 by FBC ratio was 50% a year ago. Her general practitioner carried out a trial of 40 milligram prednisolone for 1 week, but this did not lead him any improvement of the liver lung function. The patient continued to smoke 20 cigarettes per day. On examination, blood pressure 42/90, and her pulse is 80 and regular. She has bilateral poor air entry on auscultation and wheeze consistent with emphysema. Blood investigation, hemoglobin, WBC, platelets, sodium, potassium, creatinine, everything normal. What is the appropriate next intervention? Eclidium and the formoterol combination.
Eclidium. You have to add long
What is this
acting and
eclidium?
eclidium.
Laba, na? Laba.
Lava.
Sorry, lama.
Lama. Formoterol is
Yeah, it's a steroid not responsive.
Yeah.
Yes.
Yes.
Yeah.
This patient.
Mm.
So, no need to read. Go for next.
Yes,
How can we
yes.
know, remember this drug brand name? This is difficult.
Yeah.
What is the most appropriate?
Formoterol C and go for this answer.
What is the most appropriate intervention in this patient?
Protein 1 plus, blood 2 plus, yes or raised.
Yeah. Yes, raised. Okay. 18-year-old man present to the ED with complaining of rash affecting the buttock, backs of his legs, and ulnar aspect of the arm. Okay. Experience abdominal pain and the joint pain affecting the knees and the both ankles. Okay. Respiratory
I think it
infection
is
few days.
HUS.
Yeah. No HUS, not HUS.
No, not HUS.
This is HPS. Henopus colon HSP.
HSP. Henopus colon purpura.
Arthritis present.
Arthritis.
Yeah, pain
and
Treatment will be
abdomen.
supportive.
Pain abdomen, arthritis.
Pain abdomen, yeah.
rash.
But if it is
rash.
severe, you have to give treatment like a steroid and some.
But most of the time is
Usually supportive. But if in renal involvement is there maximum, then you have to give some treatment. They are asking about intervention. ESA, cycloprednisolone, and supportive therapy.
Yeah.
Supportive.
Yeah.
The patient is experiencing Iga vasculitis, evidenced by the abdominal pain, purpuric rash, joint pain, proteinuria, and hematuria on the urine testing. The presentation of Iga vasculitis often follow the RTI. These patients have BP, creatinine are normal. So this situation, supportive therapy is the most appropriate next step. Okay. BP and creatinine will be normal, then supportive treatment. NSAIDs can be used to control the joint pain, but they should be used with caution in the patient with abdominal pain where there is a hypertension and or the abdominal creatinine angiotensin converting enzyme inhibitors are the intervention of choice. There is no evidence of corticosteroid modulated renal disease.
We can use NST and the AC inhibitor, right? As what they are.
Yeah.
If pressure is raised.
Yeah.
Pressure raised, creatinine deranged. So this one is most likely diagnosis. So here creatinine is raised, bicarbonate is low, potassium is on the higher range. Okay, everything is normal. 67-year-old, cardiology, type 2 diabetes, failure, heart failure and diabetic nephropathy, failed to tolerate the ACE inhibitors and because of the rise potassium without the significant change in creatinine. On examination, blood pressure is 139/85, pulse of this, and crackles on the both bases, and the body mass index is 30. So diagnosis, they are asking about diagnosis.
Type 4.
Type 4, yeah.
Yeah.
Type 4. How it is type 4? Okay.
Potassium on the.
Just a minute.
Type 4, type 2 and type 1 is not. It's a renal artery.
Renal artery stenosis.
It can be renal artery.
I think bicarb will be on the higher side.
But look, they are saying after initiating the ACE inhibitor, creatinine is not rising.
Yes.
So yeah, it shows out.
Creatinine to raise 158.
But after that one is not rising. It might be underlying some. There's a diabetic nephropathy.
Okay, this is type 4 because bicarbonate low. Bicarbonate low.
And diabetic nephropathy is a cause, one of the cause for
diabetes is the cause, yes.
Diabetic nephropathy.
And bicarbonate low, acidosis. Type 4.
Patient is diabetic.
This patient is experiencing borderline metabolic acidosis with the potassium level at the upper end of the normal range. They are taken together with a history of diabetes and worsening hyperkalemia on the initiation of the ACE inhibitor. This fits well with the diagnosis of RTA type 4. This has resulted from the deficiency of aldosterone axon. RTA type 4 is most commonly seen in the patient with diabetic nephropathy as chronic interstitial nephritis. Okay, once go for that renal artery stenosis.
Go
Renal
up,
artery
go up,
stenosis. Go up.
go up.
Up.
Up, down.
Up, down. I also confused. When Dr. Khosed asked me go, and I will go used to go down.
And now we want to read this renal artery stenosis. Just-
Where is renal artery stenosis?
Yeah, one.
Little bit. Okay, yeah. Renal artery stenosis is acute cause of hyperkalemia in response to the ACE inhibitor initiation. However, a significant rise in creatinine would be also expected. So this one is a 41-year-old man brought to the ED with the ex-partner. He has thought to have drunk a large bottle of methanol. Very good.
So
And
antidote
left
of
a
methanol.
side note. Yeah. So fomepizole. Yeah.
Fomepizole.
What is the mechanism of action?
It inhibit the aldehyde dehydrogenase and the yes. The one is acetyl. First step is acetaldehyde dehydrogenase.
Alcohol,
and then
na? Alcohol
aldehyde
dehydrogenase. Alcohol
Yeah.
dehydrogenase and then aldehyde dehydrogenase.
Yeah,
Now, in
basically
in case
block
of
the aldehyde and prevent formation of formic acid, which is
Formic-
detrimental to the eyes.
yes.
The
Both
difference
enzyme.
between ethanol and methanol is eye involvement.
Yeah.
Methanol has the eye involvement,
Yes.
and the ethynyl glycol causing the renal involvement mostly.
Ethanol, yes, it lead to multiple. Hypocalcemia is also significant of ethanol.
Ethanol, okay. Hypocalcemia, you are saying?
Yes.
Okay.
Okay, go to the next. A 45-year-old old present with the gastroenterology clinic for review. He has been experiencing vague abdominal pain affecting the right upper quadrant, nausea, some gradual weight loss, and intermittent fever over the past few months. He is a sheep farmer and take no regular medication. Okay, examination apyrexial, blood pressure 121/82, pulse of 70, and there is a vague tenderness in his upper right and the quadrant on palpation of the abdomen, and you can feel a liver edge. Okay. Hemoglobin 123. No. Sheep farmer hepatomegaly. This one is hydrated.
Hydrated cyst, okay.
So echinococcus granulosis positive. And one cyst 5 centimeter, small daughter cyst 2.5. Go the albendazole.
Albendazole.
This patient is suffering from the hydrated disease, potentially due to his job as a sheep farmer, where he is likely to have exposed to the echinococcus cyst. The constellation of the right upper quadrant abdominal pain, hepatomegaly, nausea, and the weight loss indicate the liver involvement, which tend only to occur when the cyst are over the 10 centimeter in size. The cyst seen on the ultrasound, coupled with the abnormal liver function test, confirm the diagnosis. Infection can persist for many years before the presentation. Albendazole is the chemotherapeutic intervention of choice. Mebendazole can be used if the albendazole is not available or tolerated. Both drugs are available on a named patient's basis in the UK. Okay. AMA positive. Go for Urso.
Mitochondrial, yeah.
There is two things, yes. One is disease progression and one is pruritus.
Yeah, for pruritus, cholestyramine, and for
Cholestyramine.
disease
Yes.
progression.
If the
Urso.
disease progression, then
Also,
UST.
Definitive treatment is
liver transplantation when the bilirubin is more than
100.
100, more than 100, and the patient lifestyle become
What is the most likely finding on the skin biopsy of this patient? Okay, 23-year-old women, dermatology clinic undergo a biopsy of rash.
It's pemphigus.
Okay, pemphigus. Okay, pemphigus is suspected. Okay.
So immunoglobulin deposition throughout the epidermis.
No,
Yeah.
no. Can I go
Yeah.
down?
Dermal junction.
No. This one is
Dermal
pemphigoid.
epidermal
No, dermoepidermal is pemphigoid.
Yeah.
This is
Oh.
So
epidermis.
we already mistaken for this one. Remember,
I always.
we choose that one, option D, when we did first time.
Throughout the dermis.
Dermis, yeah. Junction is
yes.
pemphigoid.
Pemphigoid is desmoglobin.
Yeah.
No,
Pemphigus
pemphigus is desmoglobin.
Hemidesmoglin has hemidesmoglin.
Yes.
Okay, let me read. Pemphigus can be differentiated from the pemphigoid on the biopsy of the presence of IgG deposition throughout the epidermis. In contrast, in pemphigoid, IgG present as a linear pattern at the dermal epidermal junction. Pemphigus is associated with the antibodies to the desmoglin 1 and the desmoglin 3 cell surface antigen responsible for the cell-to-cell adhesion. High-dose corticosteroid are the initial intervention of choice.
Desmoglin 1 and 3. Antibodies to desmoglin.
Okay, go to the next. Okay, this one is aneurysm or what?
No.
It's a mass.
Mass. Yeah, it is mass.
What is the sodium? Look at the sodium.
Sodium is
Sodium is okay.
okay.
Potassium is low here.
You have to read this question.
51-year-old reviewed in the respiratory clinic, chronic cough and worsened over the last 3 months. Developed hypertension and diabetes mellitus, smoked 30 cigarettes, blood pressure
So-
155/98, and the
Small cell.
V cell auscultation, and this one body mass. Okay, go for this. There's nothing given actually.
Small cell carcinoma.
Small cell, yeah.
How can we say that it is small? Wait.
The presentation.
Squamous.
Okay.
No, it's
Oh,
small.
No, the presentation.
There are neoplastic-like feature present.
What
Yes.
neoplastic? I didn't
Fast
get it.
presentation and
Yes, it is. Can you go up?
paraneoplastic feature.
Can you go up?
Cushing like features, but not typical Cushing like buffalo hump and stria node you will see here. You will see
thickness
metabolic
static.
Okay,
Cushing's here.
one thing here, I
Potassium.
will say that the potassium is low in comparison to the sodium. Look,
Hypokalemic
normally in
metabolic alcoholism.
the Cushing syndrome, potassium high, sodium high and potassium normally in the normal range. But in case of the small cell cancer, that potassium is gone down. Sodium will not rise much, but potassium will go down.
Good. Okay.
Ectopic, right? This is
And this one is the central one also, that is small, and the squamous is the central.
Yes.
Smoker.
Sleep.
Take your breakfast. Okay, this one is the tough one. Okay, I
Yeah.
know this in radiation pneumonitis. Size increasing. How can you understand?
Radiation pneumonitis. Okay. I think we read
Okay,
this.
read one. Okay, a 73-year-old man is reviewed in the oncology clinic having recently undergone the radiotherapy for the peripheral lung cancer, panel A, the image below, and he has a complaint of the increasing shortness of breath over the last 2 to 3 months, coupled with a dry cough. Marking for the radiotherapy are seen on the image on the right. Follow up the images at the 4th month, and the 1 year are shown below in panel B and C. Okay. So A is the first one, and panel B and C is the follow-up. It is increasing. Okay.
Here both is increasing, right?
Yeah, fibrosed part is increasing.
Fibrous part is increased.
Okay. Pneumonitis.
This patient has a patchy consolidation at a 4 o'clock position on the magnetic resonance imaging of the left lung. This is the first seen at the 4-month mark, and is also present on the image at 1 year. According to the radiation topography lines, the area is seen at the around 70% radiation dose margin. The most concentration dose is at the center over the original lung lesion. Over the time, inflammation leads to the permanent fibrotic changes. Evidence for the steroid use in this population of the to prevent the radiation pneumonitis is mixed. Some studies shows benefit associated with inhaled steroid, whereas others fail to show benefit for oral prednisolone.
Hmm.
So they are asking, saying that treatment of radiation pneumonitis is oral prednisolone.
Yes.
Oral.
What is the most appropriate intervention for this patient? 26-year-old present to his GP, describing how it is becoming increasingly difficult for him to attend the work due to stress. He is experiencing persistent flashback of at nightmares 3 to 4 times per week. In conversation, he finds himself continuously ruminating on events and the wonders if they could have been experiencing differently. While he is at
Post-traumatic
work,
stress
he
disorder.
is constantly agitated and expects the negative event to occur. He suffers from the panic attacks each time in the hearing the alarm going off. Okay, how
EMDR.
much duration? Yeah, treatment is EMDR. For 4 weeks, na we have to wait.
Yes.
Look for
Yes.
and if it is within 4 weeks, what is the term for?
Acute stress
Acute.
disorder.
Yeah, acute stress illness. Yeah. One question of past this.
Yeah.
Yes.
If after 1 month, it's called the post-traumatic stress disorder. But in the first 1 month, it's called acute stress
Acute.
disorder. Yeah.
Okay. Need to read.
Yeah.
Okay. This patient is
Okay.
This patient is exhibiting 3 major features consistent with the post-traumatic stress disorder. He is re-experiencing events, that is flashbacks and nightmares, and is exhibiting the avoidance, rumination, and the hyperarousal. EMDR is the intervention of choice and can only be performed by the specialist. EMDR is an integrative psychotherapy approach with a set of standardized protocol, principles, and the procedures. One common component of the technique use eye movement to help the brain process traumatic events. Okay, the goal of the EMDR to reduce the distress in the shortest period of time.
Yeah.
So reprocessing in the brain.
Hmm.
What is the appropriate intervention? So chest X-ray, patchy bilateral infiltration, CRP raised, ALP raised, ALT raised. So it is atypical pneumonia, like something. 21-year-old emergency department complaining of severe fatigue, rigor, myalgia, retroorbital headache, photophobia. He has also reported dry cough, shortness of breath, and the last 3 days. Maculopapular rash. He has recently returned from the working on a sheep farm a few days ago. Okay. On examination, he had a blood pressure of 105/80 and the 95, and the V's scattered coarse crackles all over the auscultation of the chest. So it is Q fever or something.
Like this here.
Q fever treatment is doxy.
Toxic.
What is the most likely cause of this patient's symptoms? 49-year-old man present to the ED with the stridor and the erythematous rash affecting the face and the neck, symptoms of hypotension. This is the 3rd episode of he experienced in the last 6 months, and the type 2 diabetes, anxiety, and hypertension. He has a current medication are pramiprazole, amlodipine, sertraline, dapagliflozin, and metformin. So what are the patient's symptoms? Most likely cause. Amlo, dapagliflozin, metformin.
Strador, Metris, Remipril.
Yeah, bradykinin.
Radically.
আচ্ছা আগের কোশ্চেনটা অ্যান্সার কি ছিল হঠাৎ?
For urticaria, which is the most common drug?
Or doxycycline.
Aspirin.
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 Aspirin. Okay.
Dr.
cause.
Khorshed pneumonic.
Upon.
What is the pneumonic?
Upon.
Yeah.
Aspirin,
What?
penicillin, opioid, NSAID.
Okay. Okay, what is the most appropriate management option? 66-year-old man present to the dermatology clinic, swelling and the skin changes affecting the both lower limb. He has a type 2 diabetes and is obese, and current medications are metformin, ramipril, atorva, and the aspirin. On examination, the blood pressure 152/84 and the pulse 74 regular. There is a pitting edema below with both knees, and the erythema and eczematous changes. There is a hyperpigmentation over the medial side of the both ankles. He has a normal pulse in both feet.
Mm.
Okay.
So this is venous ulcer.
So compression bandaging.
Yes.
I've seen 2 to 3 questions of regarding venous thrombosis, but
Mm.
always the answer is same. They are twisting the question in a different way, but answer is same.
Mm.
Yeah, the most important thing is the compression thing.
Yeah. What is the most appropriate intervention in this patient? A 41-year-old woman present to the neurology clinic. She has suffered from the urinary incontinence and the urinary tract infection for several years. Investigation has revealed a large atonic bladder. She is thought to have overflow incontinence. She has a progressive multiple sclerosis. So attends the clinic in wheelchair, although her upper limb is functioning. Go for intermittent self-catheterization.
Yeah,
Yeah.
atonic bladder.
Upper limb is functioning till we can use. Then later we have to go for
MS.
yeah, MS.
You have to check first ultrasound. If
Yeah, they already said that atonic bladder.
Okay.
Yeah, intermittent self-catheter is the intervention of choice for this patient with the multiple sclerosis who has a large hypotonic bladder, and the sufficient hand and the arm function to cope with the dexterity needed to self-catheterize is key. It is preservation of sensation in the perineal area. This is the associated with the lower risk of UTI and the versus compared to the other options such as suprapubic catheter.
Catheter.
When the arm function lost, then we can go for this one.
Diagnosis.
Multiple rheumatoid nodule.
Chest X-ray. Multiple rheumatoid.
Yeah. Creatinine, sodium, potassium high, sodium okay, platelet, neutrophil is very low, 0.3. So it is felty or something. Yeah.
Yeah.
If there is splenomegaly, then go for
Red.
Yeah, there is a splenomegaly. Look, the
hepatic
there
splenomegaly,
is an
adrenal
extensive
palpation.
nodule. Yeah.
Also hemoglobin low.
Yeah. So go for felty. Treatment.
No treatment.
No treatment.
Steroid, I think, yes.
Methotrexate all can lead
Pulse steroid.
Pulse
methylprednisolone
and plus cyclophosphamide sometimes given.
Mhm.
Actually, first
It's a
we
second
try.
name, but usually use pulse.
Yeah. First, we try to give like acute treatment of rheumatoid arthritis, like giving the pulse method, that prednisolone. Yeah, methylprednisolone. Yeah. If it is not working, add the cyclo. If it is not working, remove the spleen.
Yeah, first I have to try with the drug, then go for this splenectomy.
They mentioned methotrexate in the explanation.
Okay, I don't know. I read somewhere that question. Okay, go ahead. Let me read the management. What they're saying. A Felty syndrome is seen in the association with RA, result in the loss of immune tolerance, self-antigens, and the subsequent neutropenia. Felty syndrome is more commonly seen in the patient with the longer-standing disease. Leg ulcers and the increased skin pigmentation are also seen. Although methotrexate can lead to the bone marrow suppression, it is the initial intervention of choice. Increased doses is the first step in the management.
I don't agree.
Look, sometimes they are saying like we have to treat it as a rheumatoid arthritis. Like we give methotrexate in the rheumatoid arthritis also. So we can treat first as a rheumatoid arthritis. If it is not improving, go for
It is
acute
proven
methylprednisolone
Felty,
first.
then there is a written very clearly. If it is a proven Felty, then pulse corticosteroid is the most appropriate initial treatment.
Most appropriate in the initial treatment. And if it is not improving, cyclo. And last resort is splenectomy. Go for next.
AMA positive.
AMA positive, evidence of fibrosis.
Yeah, go for PVC. PBC complication, can anyone tell?
Cholangiocarcinoma.
No. Especially fibrosis.
HCC.
HCC.
HCC. Not
HCC.
cholangiocarcinoma is
PSC.
PSC. Yeah, cholangiocarcinoma.
That HCC and osteomalacia also. I
Yeah,
remember.
osteomalacia.
Osteomalacia and ascites thing that normally. Okay.
Osteomalacia
It
and
is
spine
associated,
problem
I
is
know.
actually presentation of PBC.
Pardon?
Yeah, osteomalacia can
This-
present at
But
the.
it can be presentation. Osteomalacia and low
Okay.
back pain is the most presentation of this PBC.
Okay. Okay.
You can have xanthelasma also. it is.
Yeah, xanthelasma also. Okay, what is the most appropriate investigation for this patient? The 24-year-old woman is admitted to the hospital with diarrhea, fever, and the abdominal pain. She has been feeling increasingly well over the past 2 days. On examination, her blood pressure is 139 by 84.
Increasing unwell, yes?
Mhm.
She is unwell.
Okay, so increasingly unwell over the past 2 days. And on examination, her blood pressure is 139 by 84, pulse of 95 regular, her abdomen is soft, generally tender, and active bowel
This is
sign. Yeah, fragmented red cells,
TTP.
92. Yeah. Why TTP?
No.
No
Has-
neurological feature.
Yeah,
ADMTS.
neurological.
Has.
HUS.
Yeah.
No, creatinine
Diarrhea.
kidney involvement. Kidney
Yeah.
involvement. This is a
Yeah.
pentad, na?
Creatinine raised.
This is TTP.
No.
And we have
No
to look for
neurological finding.
ADMTS.
In case of if you diagnose for the TTP, patient needs some
Some
neurological
confusion, some neurological
Confusion.
feature.
Temperature raised also.
What is the option? This is has.
I'll go for a ADMTS.
No.
Stool culture for E. coli.
Coli, yeah.
E. coli. This is has. No neurological. It is not TTP.
Has
No
plus B.
fever,
What
no
is the name of doctor?
D plus has. D plus
D
has.
plus has. D has. D without has. Okay.
D money.
D
Diarrhea
with
plus.
diarrhea for has related treatment is
Supportive.
Supportive
Yeah.
treatment.
in atypical.
And then we
Plasma
go for the
exchange
plasma.
equilibrium.
Okay. Go for next.
Equilibrium. No? See.
Equilibrium.
Yeah.
What is
equilibrium.
no?
Early
What
plasma.
he,
Yeah, he's saying no means supportive treatment. What is the most appropriate initial intervention in this patient? Acetylcholine receptor antibodies.
Pyridoxine.
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 AC inhibitor.
Pyridostigmine or pyridoxine.
Pyridostigmine.
Pyridostigmine.
Okay, what is the most appropriate intervention for this patient? Creatinine 112. Okay. Investigation normal only. 34-year-old man admitted to the emergency department with muscle weakness, having the recently returned from the trip to the Sweden, where he ate some local canned fish. Okay, botulism. And the blood vision, slurred speech, difficulty speaking. His pupils are dilated bilaterally, and there are the failure of accommodation. He is unable to look up because of the eye muscle fatigue. He is a pyrexial. His blood pressure is 132 by 82, pulse of 72 regular. He feels short of breath when he lies flat. His oxygen saturation is 92% on air. There is a 4 by 5 power weakness affecting the shoulder girdle.
Yeah, botulism toxin.
Botox.
Botox. So,
Botox.
Toxin.
Send to the Dr. Rajavenjo for.
But one thing here is given. Look, there is some fatigability things. What is this? He is unable to look up because of eye muscle fatigue. The second second line.
Yeah.
Botulism, na?
Unable to look upward. But if fatigability is not seen in botulism, I don't know.
But it is the acute
It's
condition.
similar
That's why you
presentation,
cannot say
descending type.
it's the myasthenia gravis or something.
Yeah, I also confused all of this. What are we thinking of?
Thinking of it is the acute condition. The patient has this canned food and the blood vision mainly these patient people are dilated.
Okay.
In case of botulism, people are affected, but in case of what I can say,
Myasthenia.
myasthenia gravis, so people are not affected. They have
Okay.
the stenosis.
And it is not the acute one, no?
Yeah, it's not the acute one. Patient have that long time history, long term.
History will be there.
Yeah.
These patients demonstrate the central muscle weakness with the evidence that is beginning with to descend, reduce the oxygen saturation, which worsen when he lies flat. Given that this patient has ingested local canned fish, botulism should be considered. Okay, go for next. Which of the following autoantibodies is most likely to be associated with this patient's muscle weakness? NTMI2.
CK is increased.
CK
Just
is
see any skin feature. that's
dermatology
normal.
area.
Yeah. If dermatology no present, then go
He
for
has experiencing
one.
proximal muscle, okay, but this is steadily worsened over last 6 months of experiencing fatigue, shortness of breath, celiac disease, okay, nothing is there. And on examination, their pulse, BP, everything is normal, no lesion.
No
So
lesion.
anti-Jo.
If the any skin rash, then go for MI.
NTMI2. No,
Mm,
my
should
Why
have
is it not? Why is it not osteomyelitis or something like that?
CPK is
Proximal muscle.
elevated.
CK
CK raised. CK
raised.
raised.
1000.
Very serious.
Yeah.
Okay, okay.
calcium
Okay.
normal.
There's
Okay,
one more
okay.
specific antibody, right? In case of
Yeah.
this one,
Hmm.
what is that antibody name?
Which one?
Which one?
In case of this this thing, polymyositis, one more antibody. is there.
Anti-Jo1. Anti-Jo1.
No.
No,
Anti. not,
SK something.
Transfer RNA.
ETG.
No
Please.
TTG. Why TTG?
No.
No.
There is soluble signal something where this
Signal recognition protein.
yeah, SK something.
SRP.
Anti-synthetase
Signal
antibody.
That is
recognition
anti-Jo1.
particle.
Look, Dr.
Anti-synthetase
No,
antibody.
No.
synthesis. He's right.
No,
Dr. Ajwardhan is
synthesis
right.
type is
It's the
anti-Jo1.
Jo1. That is Jo1. Anti-synthetase is the Jo1. It is not
No.
different one.
Different.
That is
Yes.
SRP.
Same thing.
SRP antibody.
Yeah, that's
Yeah, SRP is
Signal-
the, but that synthetase is similar to Jo1. Similar. Jo1 is the synthetase.
yeah, anti-synthetase antibody for this like PM. That is the anti-Jo1.
Yeah.
Okay.
And one more, which kidney issues related with polymyositis?
Pardon?
Polymyositis can also lead to renal involvement. It basically lead to ATN, acute tubular necrosis.
Oh, okay.
Okay. The patient is experiencing the proximal muscle weakness and a marked elevation in the CK. In the absence of the this polymyositis is the most likely underlying diagnosis, although only 20% of the cases of the polymyositis are associated with the anti-Jo1 antibodies. They are associated with the interstitial lung disease, which could be the cause of the progressive shortness of breath seen here. Muscle biopsy is diagnostic for the condition, and the corticosteroid are the intervention of choice.
This interstitial lung disease involvement, then it is the worst prognosis or no?
Not in this scenario. It
Okay.
is for that one.
No. I know, but if
Yeah.
this patient have this interstitial lung involvement, then it is the worst prognosis or no?
No. It is for systemic
Systemic
sclerosis.
sclerosis.
Systemic.
Pulmonary hypertension, cause of death.
Okay.
SCL 70.
Okay, yeah. 70.
Graves disease or what?
Grapes.
Uptake, good uptake.
What is the most likely cause of his symptoms? Okay, 41-year-old cardiology clinic review. He has suffered from the lightheadedness and the pre-syncope with intermittent fast palpitation over the past 3 months. Myotonic dystrophy, but endeavors to maintain his physical strength as much as possible with the regular physiotherapy. So blood pressure is 125. Okay, 125/82 and the pulse of 70 and regular. What is the most likely cause of his symptoms?
Dilated.
Intermittent.
In the myotonic dystrophy, what is the problem?
It is Baker's, I think.
Intermittent heart block, na?
Block,
Heart
heart
block
block,
or the dilated cardiomyopathy one?
heart block,
Heart
heavy block.
heavy
Heart
blood.
Heart block in the
Heart block.
myotonic dystrophy.
Myotonic dystrophy patient is heart block, I think.
Yeah.
What were this one? There will be
Can you go up?
dilatation or what?
Can you go up?
Most likely cause of his symptom.
They are talking about this
Underlying
patient
myotonic
symptom, I think,
Symptom,
the
yes.
lightheaded and pre-syncope thing.
Recent cough and fast palpitation.
I thought it's a Baker's.
Fast
dystrophy.
palpitation.
I didn't read.
They are
myotonic.
already given myotonic dystrophy here.
Yeah, my mistake. I didn't read myotonic.
Okay, go
They
They are
to
have
asking
this first degree heart block, but they are now
Yeah,
talking about
prolongation,
this scenario.
This scenario.
Light headache, pre-syncope, and the fast palpitation. What are these feature for? These
Oh,
Mhm.
first degree heart block will not cause syncope, no? That's what.
Mm,
Yes.
And this palpitation.
And not palpitation.
that one to some fibrillation
what are the
or
other
dilated
options?
cardiomyopathy.
Dr. Sohrab, what are the other options?
Paroxysmal atrophy.
AF and the VT.
If
AF, paroxysmal AF, that is
Uh,
pre-syncopal feature.
Yes.
but that can be due to this one also, no? Dilated cardiomyopathy also.
This
Paroxysmal AF only.
Okay, let's see.
Mm.
Atrial tachycardia are the most commonly seen on the patient with myotonic dystrophy, and this fits with the episodes of pre-syncope and the fast palpitation reported here. 80 may affect the up to 25% of the patient with the myotonic dystrophy. Confirmation of this diagnosis with the 24-hour electrocardiogram monitoring is the next step to be followed with the electrophysiological studies. Okay, next. After this, we can stop, no?
Yes. Hungry.
Bravo. Yeah, I'm hungry.
Branch retinal.
Yeah. Dr. Priyanka's favorite. Bravo.
Yeah. Okay. So echo 31%, bilateral upper lobe diversion, moderate aortic regurgitation. They are asking about the next intervention. What are they already given?
Given. Yes. Potassium is okay.
78-year-old.
Arthritis 88.
And yeah, his current medication is 2.5 bisoprolol given.
we can start with spironolactone. We can start.
Yeah.
Why not ivabradine? Pulse is 88.
First,
First,
spironolactone.
spironol, then the
That's it.
ivabradine.
Ivabradine, okay.
Yeah.
Any option is spironolactone?
I think. Okay, just let's see. Spironolactone. Yeah,
Yes,
they have
spironolactone. They are increased. Fast increase.
Okay, can anyone say like what is the maximum dose of this bisoprolol, raniprazole,
10. Raniprazole is 10 milligram.
and the bisoprolol?
I have no idea bisoprolol.
Because
Bisoprolol you can go up till 20.
20?
20. You can
The
use up till
Raniprazole?
20.
Raniprazole 10.
Until 10.
Okay.
So why they are increasing here ramipril first, not adding the rest? Okay, let me read the explanation. This patient has the aortic regurgitation. Okay,
Ejection
aortic
fraction is low.
regurgitation. Aortic regurgitation, the main
Aortic
reason.
regurgitation treatment is bisoprolol.
ACE inhibitor.
Yes,
Yeah, because the if there will be simple heart failure, then we have to go for that spironolactone, not the ACE inhibitor. But here the aortic regurgitation, as evidenced by the murmur, he is likely to be poor operative candidate given the low ejection fraction. In this situation, with the systolic BP of 148 by and there is an opportunity to increase the dose of the ACE inhibitors to optimum the left ventricular function. Once the ACE inhibitor is maximized, increase the beta blockade may further improvement in this patient symptoms and impact on the prognosis. Okay. What is the management of aortic regurgitation?
The valve, if the patient is symptomatic, then go for the valve replacement. If asymptomatic, then see the ejection fraction more than less than 50. Left ventricular systolic diameter less than 50, and left ventricular
70.
diastolic diameter more than 70.
70.
Yeah. Okay, good. Well done.
Yes. Indication of surgery. no?
Okay.
Always
That is
wrong.
surgery.
Surgery
Yeah,
indication.
this is the indication.
Yeah.
The asymptomatic, in
Yes,
case of asymptomatic patient.
Dr. Sohrab, are we done?
Yeah.
More.
Dr. Sohrab, which year
Understand.
paper?
They're taking the beta blocker is contraindicated in aortic regurgitation.
But they are saying after that one you can add.
No, you can add for this patient heart failure feature.
Yeah, heart failure, not for the
Heart
acute
failure.
failure.
Yeah.
And in case of aortic stenosis, the ACE inhibitor is contraindicated.
Yeah, aortic is clear.
yeah,
Dr. Sohrab, are
Yeah.
we stopping?
yes. So
Okay.
next our session will be start at 11.
After 1 hour.
Yeah,
After 1 hour, we do these the question solve.
yes.
Yeah.
Past
Papers.
paper.
After completing past
This
paper,
one is which one? Which year paper?
It's
2020.
2020.
2020.
One paper. Yeah, 2021 paper. October paper, right? This one.
this one 2020 October.
2020, na?
Yeah,
2020.
It only has only one. Right.
One.
one date. Yes.
No, the one we are doing this one.
Yeah, this one is 2020, October that.
Mm,
Okay.
Okay. So next week.
Okay, thank you.
Mm.
Thank you.